last night, and I cannot believe I did this. I thought I had uploaded those
I think it was
changes.
at some point, because I
Well,
already have it.
what happened to it?
I don't know. I had it at one point, and then I lost
Okay,
it.
so, okay, thank you for at least helping me, because what I had done last Wednesday, I got everything caught up, and I tried to stay pretty tight, ever since then. So I thought I had uploaded that.
I know where it was.
I'll tell you, one thing happened earlier, when I'm operating at home in that one, not in that one zone, or whatever that, platform is out there, I've had stuff that I have put on my computer there that I have brought here, and it doesn't show up. And I'm not quite sure why it doesn't do that, because if it's on my computer and I'm on my own top, and I pick it up in the new zone, why would something disappear? I mean, I really don't know. Okay, I put it up there again, is it up there now? Okay, I figured somebody would have said something earlier if it hadn't been there, so it's just kind of weird, it's just kind of an odd thing. Anyway, y'all can send me notes anytime, I'll try to figure out what it is, so I just don't want y'all to be behind on getting stuff organized. Okay, today's kind of an interesting day. We're going to do personality disorders. I think they're actually really interesting. Pretty fascinating stuff. And then Dr. Tess is going to talk about anxiolytics and some of those agents that we kind of mentioned without really kind of getting into the weeds on them. So she's going to do that at 10. And then we have a guest lecturer coming this afternoon at 1 o'clock who's going to talk about autism spectrum disorder. She's finishing up a PhD at Oklahoma State University. I think she already has a social work degree, but I could be wrong about that. But it's her interest. And she has done a lot of work with autistic children, so I think that's going to be pretty good. And that pretty much will close out today. The personality disorders, there's a lot of stuff in here. If I do not, I'm not going to jam it down. If we make it, we make it. If we don't, I'll just finish up what piece I'm going to do tomorrow in that 1 to 3 block, because I may not need all of that block for the somatic disorders. So we'll see. So I'm not going to speed. So if you see a lot of content and the clock is narrowing down, don't worry. We're going to get to everything. So I'm not going to jam it at the last second to get it done, because I think it's important to understand personality disorders on a lot of different levels. So let's go ahead and get into it. Okay, that looks like a pretty impressive list of things right there. That's the DSM-5 personality disorders, and there are 10. Paranoid, schizoid, schizotypal, antisocial, borderline, histrionic, narcissistic, avoidant, dependent, obsessive compulsive, and it's very different from obsessive compulsive disorder that we talked about. An obsessive compulsive personality disorder is different than obsessive compulsive disorder, straight up. And then the other catch-alls like DSM-5 is likely to do personality changes due to another medical condition or other specific personality disorder and unspecified personality disorder. So I guess they're leaving room in the book for new personalities that emerge. I don't know that we've had any new ones pop up anytime recently, but it's there. Okay. Before we get there, how many of y'all have studied personality disorders? I know some of you have done psychology, okay? So you've been through it at least one time back in the past. Okay. Let's look at it a little more. Here's things referred to as clusters. Personality disorders can be grouped together based on similarities of the way they behave. Variations, of course, within a grouping, but a uniqueness. You don't have to remember cluster A, cluster B, or cluster C. You don't have to remember that. I'm just giving it to you because it's terminology that you'll see out there sometimes. It is mostly put together for research purposes. A long time ago, when they were doing earlier research on personality disorders, they grouped them like this because it had some meaning for how they were going to organize their information, who they were going to go after, looking at, and things like that. So it really has it's more of an academic research designation than it is anything you need to know clinically. But if I don't say it, you're going to see the words cluster A, and we're not talking about cluster F, just cluster A, cluster B, and cluster C, and that's it. But you need to know that term because you might see it. What's interesting about those 3 clusterings is cluster A is the paranoid, schizoid, and schizotypal, and those individuals all appear odd or eccentric in some way. Cluster B are the individuals who appear dramatic, emotional, or erratic. And then the C types are anxious or fearful. It's kind of like a baseline characteristic. So it's kind of interesting, but there you have it. Now you can forget it, but don't worry about it. All right. We all have a personality. I mean, obviously we do. We have a lot of personality traits. And a personality trait is just simply an enduring pattern of perceiving. How do you look at the world? How do you relate to it? How do you think about it? And how do you think about yourself? And it shows up in a lot of things. You know, your relationships, your work, you know, how you organize yourself, how you just think about problems that come your direction. So we all have those personality traits. It's only when your personality traits become very inflexible and maladaptive that they can cause problems in your functioning. You may be impaired, or they may cause distress in some way. So everybody has a personality. It's only when they become more extreme, fixed, rigid, inflexible that they actually begin to be problematic for that person. Okay, here's an example of pathology on a continuum. Let's say some people have obsessive compulsive traits. A lot of you all do, and just in different things. Need material at a certain time, function with my notes this way, have to do so and so that way. Those are obsessive. Those are actually obsessive approaches that are repetitive. But the baseline of that is trying to be very conscientious in the way you define being conscientious. But look at it, it's adaptive, okay? Being conscientious, I like to take my time and do things right. Okay, that's not abnormal or weird, that's just kind of a way of doing stuff. Okay, subclinical might be the person who says, sometimes I think others will disapprove of me if they find even one small mistake. Okay, now that's starting to kind of range over into another territory. Disordered would be, I find it hard to stop working until I know others will be satisfied with the job I've done. Now there's some problem of how you are managing your obsessive tendencies, which is being conscientious, into what are other people going to think about me. All the way down to very disordered, I check and recheck my work until I'm absolutely sure that no one can find a mistake in what I have done. Okay, now that may be a problem, depending on how extreme it is, and how inflexible it is. Okay, all of us at times kind of get too far in one way or the other, but we can modify ourselves and we can see it's not working. I need to kind of alter, I can change and go a different direction. When you cannot, and it becomes very rigid and fixed, then you may have a personality disorder showing up. Okay, so just trying to put out there personality versus personality disorder. And it's really a matter of degree, range, and how fixed it is in that person. Okay. So DSM-5 has general diagnostic criteria for personality disorder. This just gives you the broad approach to it. Their definition for personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations from the individual's culture. Okay, and that's an important element. I didn't underline it, but I should have. Personality is very dependent on the culture you're in. Things that we do here that fit in and nobody makes a note and takes any notice about, you could be plucked up and put in another culture and they would think, you're weird, there's something wrong with you. It's not the way we do stuff here. So you could be falsely labeled in another culture, just like we falsely label people from other cultures who come to the Western culture. So it's not even as stable as we might think. It really depends on your context and how are what do the people in your culture think is normative. You know, there's a range of behaviors that we can tolerate, but then when you get over one way or the other, then you start to be abnormal within that own culture. So it's an enduring pattern of inner experience. How do I experience this world, and how do I behave within my experience? When it deviates from the culture at hand, you may have trouble. The pattern is manifested in two or more of the following areas. Cognition. How do you think? How do you put thoughts together? How do you look at something and assess it? How do you think about it? Affectivity is just your expression, you know, your affect. Range, intensity, lability, how you know, from one minute to the next you're sad, mad, whatever, and the appropriateness of emotional response. So that's all about affect and how you show up, you know, how do people see you. It also gets into interpersonal functioning and also impulse control. So strange deviations in the way you think and put things together, strange ways that you express yourself, and how intense that is, and how ranging that is, how you function with other people, and how well you can control your impulses. I mean, we all have impulses. I mean, we all have impulses, but we tend to keep ourselves together. Like if somebody does something I don't like, it's kind of like, that's the stupidest thing I've ever seen. Okay, well, am I gonna say that in public? Well, I mean, no, I mean, not usually. You know, sometimes you might let it fly, but if that's just a basic pattern, then people start staying back because they don't know what's gonna come out of your mouth or what you're gonna do. Okay, so cognition, affectivity, interpersonal functioning, and impulse control are the areas where you have to have some change in the pattern of behavior that makes it a personality disorder. Okay. Now, the enduring pattern that we're talking about has to be inflexible and pervasive across a broad range of personal and social situations. Inflexible and pervasive. You'll see this in the diagnostic criteria over and over again. The pattern leads to clinically significant distress or impairment. So the person's personality could actually cause a lot of grief to them, and they're very unhappy about it. And certainly problems function with other people. And it shows up in their social situations, their workplaces, and any other area they function, like school or things like that, or going to a party if your personality disorder would even allow you to do such a thing, and there are some that don't. The pattern is stable. It doesn't really change. It's not like, well, last week they were this way, and now this week they're this way. Now that could be true for an emotional, you know, it can go from here to there, but that's part of their fixed behavior, is that always shifting around, you know, emotions. It's stable, long duration, and usually personality disorders show up in adolescence and certainly by early adulthood. You know, you see children that you say they're kind of odd. Okay, they might be an emerging personality disorder. And we see a lot of things that are quite normal. And then as they grow up and begin to really connect all into the world, it begins to show up. So usually by adolescence or early adulthood, you kind of know a personality disorder. And I'm not sure how much anybody thinks you can actually change a personality. I don't think they really think it's possible, but I think you can manage your personality if you know what it is. Okay. The pattern is, this is the DSM-5 standard. It's not attributable to another mental disorder, medical condition, or physiologic effect of substance. So just to keep drumming the point home, when you're evaluating people for anything in the world of psychiatry, you're always ruling out substance abuse because drugs can change the way you think and act significantly. You got to get rid of those, and you got to rule out other medical conditions or other mental disorders where what you see as odd is classified appropriately. Okay, now you can have a personality disorder and major depression. You can have a personality disorder and schizophrenia. You can have a personality disorder and a mood disorder. I mean, you can have a lot, you know, a panic disorder. You can have a lot of combos of things. So it's not like once we've got your label, okay, well, you're a personality disorder, thank you, next. You know, they can be multiples. Okay, why is it important to know this? You know, if there's not much you can do about it anyway, why do you need to know it? It's a good question. Well, here's why you need to know it. You need to know who's sitting across from you. You just need to know who's in the room. I've said it a lot of times with people, and I'm not ever quite sure it's completely appreciated by students at a certain point, is you really need to know who's in the room. That I could not emphasize that enough, because if you don't know who that person is, I mean, really, you know their name and address and all this stuff, and you know their diseases that may be listed out there, but who are you? How are you going to act? What are you thinking? How are you receiving me? How are you going to do what you need to do? You have to have that for a relationship that's effective. So you've got to know who's sitting in the chair. It will enhance compliance. If you don't know what they are, who they are, how they function, if you just keep laying out your same old way over and over and over again, then that's going to work for some people and you'll love them. Oh, they're just the best patients. Then there'll be other people who don't really work real well, and you go, I don't know what's wrong with them. There's something wrong with them. Well, maybe it's you have method A, method A, method A, method A, method A, method A, and it's not the same person over here. So it will work with a good number, but it won't work with some other people. And the more you begin to pick up on that, the better off you're going to be in communicating and dealing with those people and keeping a patient clientele. You mean seriously, because if you don't really work well with folks like that, they will walk. And it also reduces patient stress. When people come to a provider, they got a problem of some sort that they want you to attend to, and if you can't really get with them in a way that they can receive, their level of stress doesn't go down as much as it should. In fact, I've seen providers actually agitate patients. What they're doing is wrong for this personality type, and then there's no good outcome, and the provider's frustrated, upset, and so is the patient. Well, healthcare did not happen. Just not going to happen. So the more you can get a grip of who is in the chair opposite you, the better off it'll be in practice. Now, I'm not saying all these people are fun to sit around. Okay, now there's some personality disorders where you just go, because that's the nature of the personality. Okay, so you will have to figure out who you are as a provider, and that's part of you developing your emotional toughness of a certain sort or emotional distance when it's appropriate, as opposed to being drawn into every personality type. My basic personality type, I like to kind of know people. I like to know them and kind of meet them at an earthy level. That's what makes me feel good. Well, I will tell you what, some of these personality types, if you do that, they will work you over, and you won't even know how worked over you are until they have done, and they've done it to you. So I'm a little more savvy than I used to be, but I would still say I'm prone to, I'm trying to be very honest and connect with people. And sometimes folks are not wired to take it that way. And you won't know until they just let you have it one day, and then you'll be so upset. Okay, so I don't want y'all to end up like that. Okay, but it will. I'm telling you, the things will happen. That's what makes it fun. Really, it does make it fun. Okay, so let's look at some of the personality types. And I have great clips on everything. I mean, there's just really some good stuff out there. So it's the best way to do it. You can talk about a personality disorder all day, but watch a little bit of somebody in action. Go, oh yeah, that's so-and-so. Okay, that's Nathan Brown. That's Ron Brown. That's Jordan Gooch. I wonder what you are. Okay, that you're just normal. Okay, we hope. Okay. So let's look at that first group of A, and those are the people. The A people are what? They're kind of eccentric, kind of odd. Okay, so here's one. Paranoid person. See, he thinks somebody's talking behind his back. Well, maybe they are, and maybe they're not. Okay. All right, here's DSM-5 diagnostic criteria for a paranoid personality disorder, and I have bolded in yellow on each one of these some of the big turn point things you got to remember for the diagnosis. It's a pervasive, there's that word again, pervasive, the personality is pervasive and flexible. A pervasive distrust and suspiciousness of others. So they basically distrust or suspicious of everybody, such that their motives are interpreted as malevolent. So they won't trust you, but not only do they not trust you, they think you're working against them. There's something bad. No matter what you say, there's a motive. And the motive is not a good one, and they're out to get you. And it starts in early adulthood and presents in a variety of contexts. And here's 4 or more of the following areas. First one, they suspect without sufficient basis that others are exploiting, harming, or deceiving them. They're preoccupied with unjustified doubts about the loyalty or trustworthiness of friends or associates. See, it's unjustified. They cannot control it. They have the sense. And so they are unfairly judging people as disloyal or not trustworthy. They're reluctant to confide in others. They don't talk to people. If you don't trust people, then why are you going to tell them your secrets, your deepest concerns? Because of their fear that if they give it out there, the person's going to use it against you. I can't really say that because they might use it against me. Okay, now in a non-pathological way, we're all like that. I don't tend to want to go tell power figures things about me, because if that person has some power over me anyway, why am I going to tell them the truth about something? What if it's something about them that isn't the best thing? Are they going to receive that well, or will I not? And from being a faculty member for a while and being with students, there's always this thing about the student and the teacher, like, well, if I really tell you something I don't like, well, you'll probably use it against me, you might affect my grade. Okay, that's just kind of that's not abnormal. But it is kind of a baseline for many students, is not really to feel comfortable coming forward and saying stuff because maybe you'll grade me down. Okay, because biases exist and we've all seen it. Okay, biases exist in subjective grading. Now, if I get all the test questions on multiple choice, you can't do anything to me. But if you don't like the way I write something, then you can do something to me. And it's more get away with it. So that element's always out there in an education environment. But that's not necessarily abnormal. But theirs is abnormal in all kinds of ways. You know, their boss wants to ask them something, can't tell you. Want to talk to your wife, can't tell you. We're not going to let you know stuff. They read hidden, demeaning, or threatening meanings into benign remarks or events. So no matter what's said, they will find out how that's bad. And you actually see that in kind of a normative way with some people. They just have a negative take on life. And no matter what happens, they always believe bad things are going on. It may not be pathological, but it might. You know, you might want to look at them a second time. They persistently bear grudges. That is, they're unforgiving of insults, injuries, or slights, and they will remember everything. You know, 2 years ago you said so-and-so to me, and I'm mad at you for 15 years afterwards. And I've had students, you may say something casually, it'll be received as an insult, and you'll see them 10 years later, and they'll go, I don't remember when you said so-and-so to me in class. And it's like, really? Really? Go get help. It's like, come home. If we all did that, the world would blow up. If we all did this, the world would blow up. Okay, they perceive attacks on their character or reputation that are not apparent to others, and they react angrily or they counterattack. So they do interpret the world in a negative way against themselves. And they have recurrent suspicions without justification regarding fidelity of spouse or sexual partner. You're cheating on me. I know it. You didn't come home right at time. Where were you? Who are you cheating with? I mean, you can imagine the number of divorces that happen in situations like this. If the marriage happened in the first place, how would it stay that way if you were a paranoid personality? Well, probably not. Okay, does not occur exclusively during the course of the disorder with psychosis and is not due to a general medical condition. The DSM-5 rule out other disorders. So let's see what this looks like. Okay.
Hi, my name is Jordan Jackson, and I have paranoid personality disorder. I would say this all started when I was walking to work one day, and I felt as though this man was following me. And I'm 95% sure, no, I'm 100% sure that that man was following me. He was this man, and he was 6'4", he was black, and every time he just walked near me or walked in my vicinity, I was petrified. And if I turned a corner, he turned a corner. He was just chasing after me no matter where I went. And it has affected my life in many ways. An advantage of being as paranoid as I am is that I'm always cautious, and that means I'm always safe. And that's honestly the best thing you can do, because there are so many people out on the street that can't be trusted. A disadvantage of this would be is that I don't really have a personal life or a social life, because I don't get a chance to connect with people because I don't trust them, because people can't be trusted. This is the most contact I've had with somebody in a really long time. One thing about my disorder is that I'm constantly moving because I have a tic, and I always feel the need to look over my shoulder and see what is happening, because you never know who's near you. Another thing is that I don't trust a lot of, wait, hold on, sorry, like, I don't know if you guys see that, but like, there was movement over there. Like, that's the stuff you have to be careful for, because you never know. You never know, because the person behind you could be a killer, could be a rapist, could be a mugger. Always be cautious of your surroundings.
I thought it was kind of odd when she's sitting there saying there's somebody out there in the bushes. That really that's, you know, she's sitting there being, you know, she's still kind of watching and stuff. Okay, y'all know anybody like that? Y'all know any people who are like that? You may not know any, but you might. Who? How common is it? Well, it's not that uncommon. 2.3 to 4.4%. You know, a lot of this. I'm going to give you stats on every one of these. I do not expect you to remember the stats. I'm just going to tell you right now. I just think remembering all kinds of numbers like this is insane unless there's a purpose to it. When you look at how would you know, do you go out there and do personality inventories on a big sample of people and then extrapolate that to the population? What they do often is they get statistics among patients who are being seen in healthcare environments. Okay, that may be skewed to those who were in the system. What does that mean about all the people who never choose to go into it? And what is the general population versus what is the clinical population, the people who are seeking health care? So a lot of these statistics range, and I would say take them all with a grain of salt at a certain level, but 2.3 to 4.4, but these are DSM-5 figures that are coming out. Men are affected more often than women. Appears in childhood or adolescence. Odd behaviors attract teasing a lot of times from those folks. And this is kind of by definition appears in adolescence as a personality disorder. Maybe more common in family relatives of people with schizophrenia. Okay, so you know, in schizophrenia, what's one of the common markers? Paranoid delusions. What was that? Okay, was that like lightning outside that messed up my screen? Seizure. Okay, but it may be more common in family relatives of people who have schizophrenia. It may be a smaller variation of that paranoia, but it's not a delusion, but it's a thought process. Interesting. Members of minority groups, immigrants, political and economic refugees, or individuals with different ethnic backgrounds may be inaccurately labeled with this disorder. Because when you go to a new country, you know you're not going to be that comfortable with all of what goes on. And so what you might do is tend to stand back. I know when I went to China, I didn't interact with people. I couldn't speak Chinese, and I didn't know what was going on. And so you're more off to the side, you're watching, you're interacting, but you're not very interactive. You can't speak the language, you don't know what's going on. And so you just kind of watch stuff. So if you're a native and you're looking at somebody like me, it's like, there's something wrong with you. Well, okay, I don't know where I am. That's what's wrong with me. I can't figure this out. Okay. But I don't put this on all of these slides about disorders, but mostly this is culturally relevant that when you see people from other countries, they very often get tagged with these personality disorders, but it's more kind of a bias of our culture against their originating culture. How do you interact with a person with paranoid personality disorder? Admit mistakes, don't be right all the time. Be forthcoming and honest, gotta tell the truth. Have a professional demeanor but not overly warm style. If you try to really hug them or get in with them, they may wonder even more, what are you up to? You know, you're being nice to me, but what are you up to? Don't confront, and you have to set limits and clearly explain procedures, medications, and results. So it's really, you have to be very honest, straight, and vanilla, and you have to live up to what you always say you'll do, so that there's this expectation that when they say something, it does work that way. If they say they're going to do this, then they do that, because if you don't do what you say you're going to do, they'll begin to not trust you, and then they will become more suspicious about you. don't get too tight with them because they won't be able to interpret that. Or they will, and it won't be a good interpretation. Okay. Any question about paranoid personality disorder? These next two are really bizarre, I'm gonna tell y'all. Okay, schizoid personality disorder, these people really are quite odd. Okay, the picture is notable because this person is by himself. That's a huge thing. Alone, one, not with folks, sitting off way out here. That's kind of typical. Okay, so here's your category. A pervasive pattern of detachment from social relationships and a restricted range of expression of emotions in interpersonal settings. So these are quiet people, they don't really connect with you, you want to, but they don't. They're just kind of odd separations. When you're talking to them, if you're trying to really engage, you can't feel like you're really connecting. You kind of get rebuffed a little bit. 4 more of these things show up. They neither desire nor enjoy close relationships, including being part of a family. Yikes. Almost always choose solitary activities. Have little if any interest in having sexual experiences with another person. They take pleasure in few, if any, activities. It's almost an anhedonia, but not that deep in. Lacks close friends or confidants other than first-degree relatives. The family you're born into might be the group that you talk to the most. You're not going to be talking to new people all over the place. They appear indifferent to the praise or criticism of others. So you're saying something to them, you don't seem to get much of a response in this. They don't really react to it. They show emotional coldness, detachment, or flattened affectivity. Okay. Of course, there's lots of disorders to rule out. Are they schizophrenic? Are they bipolar, depressed with psychotic features, other psychotic disorders? Autism spectrum disorder, we'll hear about that today. What makes them so unresponsive and so distant and far out? Note, if the criteria are met for this personality disorder prior to the onset of schizophrenia, then you can add pre-morbid. So it could be schizoid personality disorder, pre-morbid, almost suggesting that they're close to being schizophrenic, but they don't meet all the criteria for that, so they're suggesting that it's a pre-morbid condition, which is kind of interesting. If you have a schizophrenic and then this personality type lasted beforehand, then they could be diagnosed as schizophrenia, also schizoid personality disorder. Okay, let's look at this one. This one I think is fairly impressionistic, but when it's all done, it pretty much is the way these people will come across to you. So just kind of take it for what it is.
What are you doing?
Luring.
Oh, it's the tree.
Yeah.
Well, yeah, it looks really good. Why did you choose the tree?
Oh, it's dead, and you can seal the branches. It's better than the other ones.
British, you
Can't see it.
Oh, alright.
Yeah.
Do you live really close to it?
Yeah. Just back there to the left.
Oh, right. No, that's really close to. Oh, it's gone. Are you going to Rachel's party on Friday?
I don't think so.
Oh, I don't know really how to go. You have to go in pairs. Because it's like, I don't know, boring or something.
No.
Are you busy?
No. Do you know, it's... don't fancy it.
Right. Yeah. I'll leave you to it then.
Good.
Okay, that was actually pretty classic because that, he's out there by himself doing his own thing, and she actually wanted to ask him out to the dance and he didn't want to go. And he didn't even like her touching her. I mean, and he just kind of shut her out. So he kind of rebuffed her pretty good. But without a lot of emotional response. I mean, he's very just within. I've seen people like this, you just don't think about giving it a label, but that was a pretty good example of that. Okay, look at the range of that. That kind of surprised me, the DSM-5 put that out, 3.1 to 4.9%. I think you see variance of it because I know people who they just don't interact a lot. They don't like to be messed with very much. They don't like to be touched. They don't like folks around them. Is diagnosed more often in men than women. And they have an increased prevalence in relatives of individuals with schizophrenia or schizotypal personality disorder. I put a list of people who have it because it's kind of an interesting list. Albert Einstein, Mary Todd Lincoln, Charles Darwin, Sigmund Freud. I thought that was pretty interesting. Stephen Hawking, Bill Gates, Isaac Asimov, the science fiction writer, Bobby Fischer, the chess king from back in the 70s and 80s, and Karl Marx. So those are odder personality types. But what's interesting to me about that list who have it is what their accomplishment was. That, they're alone, but they're thinking about something. They've come up. They have a different perspective that may be useful, for the rest of us. So kind of interesting. They're certainly not incapable of advanced thought. They just don't want relationships. Okay, what do you do with a person with schizoid personality disorder? Understand their need for isolation. If you're the life of the party person, just drop it. Okay, you're not going anywhere with that. Minimize new contacts and intrusions. They're not going to be people who like this bus station of activity in the clinic area. To maintain a quiet, reassuring, and considerate interest in them, but you don't have to touch them, and except for what has to be done for a physical assessment, and don't insist on reciprocal responses. You just have to exist with them decently, and they will exist with you decently for what they need, but don't try to go someplace they don't want to go because they have given you the message. It's okay. Everybody doesn't have to act like, they have to act like we want them to act. Sometimes that frustrates us. I mean, personally, I know sometimes I like a certain type of response. It's reassuring to me. Well, maybe that's my personality, and that's what I need. Maybe that's not what they need to do. Maybe I need to grow up and deal with it a different way. Okay, so you'll encounter this as you move along. Okay, now this is another version a little bit further down the road. Schizotypal personality disorder. This looks like Damien from the Omen, the Omen movies. Okay, let's do this one. This one, a pervasive pattern of social and interpersonal deficits, marked by acute discomfort with and reduced capacity for close relationships. Okay, so that's kind of like schizoid right there. You just can't really connect with somebody. But here's the distinguishing feature. As well as by cognitive or perceptual distortions and eccentricities of behavior. These people actually act weird. He didn't really act weird. I mean, his thought content was okay, and he interacted, you know, legitimately. He just wasn't connecting with her, and he liked to be alone. Okay, now these people actually have some odd ways of expressing themselves. And I'm not the best people to compare with this person. Weird. Okay, they have to have 5 or more of the following: ideas of reference, excluding delusions of reference. A delusion of reference is when they actually really believe that everything happening around them is in relation to them. You know, people are clapping, it's for me. People come to the room, they're coming because I'm here. And they really believe that. An idea of reference is one step back from that. You think a lot of things do apply to you, but it's not as fixed in the mind as if it's a delusion. A delusion, I really believe, is the case. An idea is your interpretation of all activity moving around you is because of you. Odd beliefs or magical thinking that influences behavior and is inconsistent with subcultural norms. For example, superstitiousness, belief in clairvoyance, telepathy, or a sixth sense. They talk about powers. Unusual perceptual experiences, including bodily illusions. Okay, they may think things about themselves. Odd thinking and speech. For example, vague, circumstantial, metaphorical, over-elaborate, or stereotype. Suspiciousness or paranoid ideation. Inappropriate or constricted affect. That either doesn't match the situation or it's a tight range of expression. Behavior or appearance that is odd, eccentric, or peculiar, lack close friends or confidants other than first-degree relatives, and excessive social anxiety that does not diminish with familiarity, and tends to be associated with paranoid fears rather than negative judgments about self. So these people will come across as odd. It doesn't occur exclusively during the course of schizophrenia or bipolar or those others. Again, this is the same way. If these criteria are met prior to the onset of schizophrenia, you add premorbid, so it'll be schizotypal personality disorder, premorbid. Okay, now watch this. I don't know if we're going to watch all of it, but I'll go for a little bit. This is a weird thing.
I understand that you had a change in your work at the library from working back in the stacks to now working out at the front desk. Is that right?
Yes.
Can you tell me more about that? What that's been like for you?
Well, my supervisor is pretty busy, and he doesn't like to be bothered. He already thinks I'm not suited for the job.
He said something to you about that?
No, not exactly. But when I'm with him, I can sense that my customers have complained.
Paranoid.
How is that?
Well, when they ask me something, I tell them. But I don't make small talk. I guess I've always been a Pluto, out beyond the rest, encircling, ever watching, and seeing more in the darkness than the rest.
I talked to your sister briefly, and she said that she hasn't really noticed any changes in you, that you're pretty much the way you usually are.
Constancy is a virtue.
Are you friends with any of your coworkers?
Well, I did have lunch once with some of them. But I've been reading such depressive books lately that when I think about them, it upsets their meal. They can feel my feelings. So, I eat by myself.
Have any of your coworkers been helpful to you recently about this move from the stacks to the front desk?
Well, we don't talk.
If you do have something you want to talk about, with whom do you talk?
I guess the last person was my college roommate.
And in what way was he helpful?
I'm not sure I understand what you're asking.
You said that your college roommate had been helpful to you if you needed somebody to talk to.
Not that often. And mainly about studies. We both worked very hard in school. I could often tell what he was thinking, and I knew when to leave him alone.
Well, where is he now?
He died.
When was that?
A few years ago.
And how did that happen?
I'm not sure. We didn't talk after graduation. I remember reading about his death in an alumni magazine. And I remember receiving a feeling that something had happened to him even before I read that story. I already felt he was dead, and often felt as though he were in the room with me. Then, when I read that story, I understood.
What did you understand?
Well, I threw his picture away just before he died.
Have you had any new or puzzling sensations recently?
Well, from time to time, I can smell a very disagreeable odor. I'm concerned that it's coming from me. It worries me.
What do you do about the odor?
I take a lot of showers, but the odor, it's malicious, piercing.
Does the odor hamper you in any way?
Well, recently I've tried to avoid getting too close to people when I'm at work at the desk, especially girls.
What sort of contact do you have with women?
Well, several work at the desk. From time.
Y'all got enough of that? Okay. I'm gonna click him back. Okay. If you wanna watch it, you can watch the rest of it later. I just wanna do this and then we're gonna take us a short break. Let's go back and look at this. Ideas of reference. Did you get that in what he was saying? A little bit, pretty much. Everything he was talking about was in relation to him. Odd beliefs or magical thinking. He saw things so dark that other people didn't see. He had senses of things before they happened. Unusual perceptual experiences and embodied illusions, yes. Odd thinking and speech. Didn't he strike you as really weird? I mean, just comes across as odd. Suspicious or paranoid ideation, yes. He had that. Inappropriate or constricted affect, yes. The man's face hardly moved an inch in any direction about anything. Odd, eccentric, or peculiar, yes. Lack of close friends or confidants, yes. Excessive social anxiety, I'd say yes. He has almost everything. Okay, an odd appearance. just to kind of keep it separate, because people always tend to get schizoid and schizotypal mixed up. You see the difference, both of those people were isolates and they didn't really interact with people, but this one has peculiar, weird behaviors. The other one, I would have looked at that as kind of a range of a possibility, like I'm just more of a loner, you know, you called him a loner. But there wasn't a lot else about him that was really strange. He didn't respond to the woman's advances like most males might interact and be friendly, even if they didn't want to go out with them, they wouldn't have been so completely rebuffing. This person strikes you as odd, and they have odd thinking. So it's that thinking part, and their expression and their what's going on in their world around them is an odder variation. Okay. Schizotypal, 3.9 to 4.6% of general population. Again, I gotta wonder about that. Maybe slightly more common in men, tends to aggregated families. Family relatives of those with schizotypal personality are more likely to have schizophrenia and other psychotic disorders. To me, he's one step from schizophrenia, literally, and you have to wonder about that. Now, this is interesting. Maybe consider the premortem personality of a future schizophrenic patient, though only a small proportion with this personality disorder actually develops schizophrenia or another psychotic disorder. So this is kind of where he is, but it doesn't go the rest of the way, but in some people it can. A strange appearance. So how do you interact with them? They're very similar to the schizoid personality disorder. Yeah?
I just, for me, when I'm looking at him, I mean, he seems schizophrenic. Like, where are you drawing the line at? I mean, he's having these thoughts about how he received a picture or threw away his picture, and like right before his roommate died. Like,
yeah, I think you would have to go back and do a full mental status examination on him to find all the criteria in all those categories, and you'd have to run back into, you know, what are the two cardinal features of a paranoid schizophrenic or of a schizophrenic? The
auditory hallucinations or visual
Yes,
hallucinations?
you gotta have that. Did he have that?
No, I guess not.
Okay, so what happens with these type of people, you would see this person, you would end up having to do a full mental status examination in all the areas, and you would have to look and see, does he have this criteria? They're just like on the jumping off point. They're, to me, it's just odd. You might ask him, what do you think? Have you heard voices? Do you hear, you know, they have to have these Schneiderian delusions, you know, they have to have these hallucinations, I mean, they have to have auditory hallucinations. So you have to go back and look at your criteria to actually call it.
Okay.
It's close. And you might go, if you get a patient like that, you probably do a full mental status examination. If they just showed up sight unseen and you start talking to somebody like that, what would you do with that? When you think there's something not right with you, you'd have to go back through the records to figure out what is he already being classified as. And if not, it would be a consult to psychology or psychiatry. I'd have somebody come in and look at and tell you the truth. It would, I'd have to get out of the room. And it would be difficult, because if you did try to suggest he sees somebody else, they would not believe, they would be suspicious of your intent. You know, there'd be a paranoia about it. So you can see why a lot of these disorders don't get diagnosed in reality, because the people themselves won't allow themselves in a situation to be diagnosed. They're not likely to go to healthcare that much in the first place. And if they do, they're going to get in and out. So your principles of interaction are similar, often have misperceptions of physical symptoms and treatment. He had some odd beliefs about body and what was going on. Thought he had this odor that was, you know, what is that? Was that a olfactory hallucination? You know, that's a question. Do not ridicule or judge them, respect their need for privacy. Okay? Interesting types. We're going to take a break. That brings us up to that's Ted Bundy.